This is the last panel. I'm very excited for it, and I feel like I just woke up in the morning, and I have so much energy for this because I'm joined with two awesome fellow young adult patients as well today. But before we get started, I'm going to introduce myself a little bit and share why I'm so excited to moderate this panel. So my name is Sneha Dave. I am the executive director at Generation Patient, which is a young adult patient-led organization, and we work to represent our community of young adults with all different chronic and rare conditions. I came to this work because I was diagnosed with ulcerative colitis when I was 6 years old, and with very early onset inflammatory bowel disease, it comes with unique challenges. So I had my full colectomy, which is the removal of my large intestine, in high school, and have sort of still been a patient ever since, and navigating what that looks like to be a young adult now. And so while a lot of these questions that we have today are going to be focused on engagement, I really want to highlight this idea of patient leadership and patient-led, and particularly enabling and centering young adults to be able to lead conversations and to lead our own opportunities for what reform can look like within our community. So at Generation Patient, I'm going to speak very briefly on this, happy to chat more. We do a variety of work, so we span everything from peer support. We've done a little over 600 peer support meetings over the last couple of years. So we're formally evaluating them now with Boston Children's. We are, I think, the youngest PIs on a PCORI award ever, which is very exciting for us too. Thank you. And then we also do a variety of work in health policy too, where we really engage and allow our community to drive some of the conversations. So we've had folks speak at the NIH, at the Patent and Trademark Office. We've gotten to visit the White House 3 times in the last couple of years. So really, again, enabling our community to lead these conversations. So today I'm joined by 2 awesome young adult patients, and I think that we could be like best friends because I think we could talk forever and ever. But so first of all, Taylor Hoffman, soon to be Dr. Hoffman, is a 3rd-year medical student at the University of Arizona College of Medicine, Phoenix, and a patient advocate who has used her extensive lived experience to influence policy, pass legislation, and teach patient advocacy and access to care insights. Hoffman co-founded a law and medicine interest group and is a volunteer with the Street Medicine Intervention team in downtown Phoenix. Manya Tarnal is a sophomore at the University of Michigan, yay Midwest, and a patient advocate with the Epilepsy Foundation of America. Last year, Tarnal served as a public health intern at the Epilepsy Foundation of Michigan. During her time there, she helped to conduct the 2023 Michigan Epilepsy Needs-Based Assessment and analyzed the data collected. The assessment was designed for people with epilepsy, their families, and their friends to share experiences and needs, both medically and in areas of quality of life. So I also just wanted to really highlight, so the last panel we talked about adolescence, and I really want to first frame the first question as who are young adults? There's a real lack of consensus among regulatory bodies themselves of who the young adult patient is. So when we look at the World Health Organization versus the American Academy of Pediatrics versus the FDA, CDC, there's varying definitions, and I think that contributes to a lack of clarity and real recognition of this immense demographic that exists. So over 85% of kids with chronic conditions are now living past the age of 18 due to the advent of new medical technologies and medications, and we also know that over 50% of young adults ages 18 to 34 now live with a chronic condition in the United States, according to the CDC. So this is a tremendous generation of patients that is entering the medical system into adulthood. So my first question for you all, and maybe we'll start with you, Taylor, is can you talk about who the young adult patient is and sort of your background and what it means to live with a chronic illness at this age?
Yeah, so like she said, my name is Taylor Hoffman. So I'm from Phoenix. When I was 1.5, I was diagnosed with type 1 diabetes in Tucson. I was the youngest patient to have been diagnosed with that, and it kind of just came as my parents thought I had drinking a bottle of nail polish remover from the bathroom because my ketones were so bad. And I had a bunch of ear infections and stuff like that, and they couldn't figure out what was causing it. And so that was actually December 31st of 1997. So I started the new year as a type 1 diabetic. So it's kind of like a weird, I don't know, kind of thing, yeah. Yeah, and then so when I was 5, I started getting sick. I was losing a bunch of weight. My hair was falling out. I didn't have energy, and I had like some really weird kind of rash that wasn't related to like diabetes or anything like that. I got misdiagnosed with cystic fibrosis. They told my parents I wouldn't make it past 10, and then come to find out it was just celiac. So just a simple test, changing my diet, and it was just, yeah, so that's kind of a really interesting story, and that happens more often than you think. I've seen it a couple times in literature, like in South America, that happens quite a bit. And then when I was 12, got diagnosed with Hashimoto's, hypothyroidism, and then just a couple years ago, I got diagnosed with rheumatoid arthritis after having, I just woke up one day and I thought I had like broken my finger in my sleep, and come to find out, no, it was just arthritis, and then it spread to like every joint in my body, which then kind of, we can talk about like the way that then healthcare changed as like advocating for yourself as an adult. But yeah, and then so I guess my experience has been having good and bad ones, where it kind of is one of those things like if someone doesn't do it right, go do it yourself type of thing. And I was always interested in science, and so I went to ASU for undergrad, and then now I am a med student at U of A. So, and I advocate for diabetics. I actually, Dr. S. Contreras, I worked with him also for the American Diabetes Association and advocating for them, helping patients learn how to go to college and advocate for themselves when they were living off by themselves. And so that's kind of, yeah, I don't know.
That was awesome, and really excited to have you as a doctor with a chronic condition. We definitely need more, so excited for that future. Manya?
Yeah, absolutely. So Sneha said, my name is Manya Tarnal. I am a sophomore at the University of Michigan studying community and global public health. I was diagnosed with epilepsy at the age of 16, so my junior year of high school. It was also kind of smack down in the middle of COVID, so in terms of support systems, it was very limited. My first seizure was November 3rd of 2020. I remember this because I was a poll worker at the elections. I don't have an aura, for those who don't know what that is, just you kind of know when something's coming in terms of a seizure. Don't have one, so I just kind of remember waking up in the ambulance. I didn't have a great paramedic experience. She did not convey to the ER doctors that it was a seizure, so they treated it like a syncope, pushed me out of the ER, follow up with neurology, see what she says, go from there. I saw the wonderful Dr. Nancy McNamara at Mott's Children's Hospital in Ann Arbor. We did an EEG. She did see a spike. However, she was like, there's no confirmed incidence, so I'm not too worried about it. Flash forward, I waited my 6 months of no driving, because that is a Michigan law. 3 weeks into that, I was at a volleyball tournament. I had gotten about 3 hours of sleep, so that wasn't a great setup for me, and had a second seizure at my volleyball tournament. I was taken to the ER, immediately diagnosed with epilepsy, put on medication. Flash forward 3 years, I am seizure-free for 3 years, so that's super exciting. And in terms of my work with the Epilepsy Foundation, I was their public health intern last summer. I conducted the 2023 needs-based assessment for the state, which I'll get into a little bit later. And then this summer, I'm going to be working as the multicultural outreach and education intern at the Epilepsy Foundation of America. So I'll be working a little bit more with the outreach and the educational aspect, given the name. And yeah, it's a little bit about me.
Awesome. Thank you so much, Manya. And one thing I want to point out as I was listening to Taylor and Manya speak is that I think there's such a difference in age of diagnosis, too. So when we think about kids being diagnosed versus what it means to be diagnosed a little bit later on, and the impact that that can have, not only on identity, but also the way that you navigate the world and navigate medical appointments for the first time often. So it's a really important point. So I'm going to start out with some sort of micro questions, and then we'll go more into the specific advocacy. But and maybe I'll start with you, Taylor. So one of the critical, I think, points and inflection points for transition for a lot of us is when we turn 26. And can you sort of talk about what it was like for you experiencing that transition, and what you might share with the audience in terms of thinking about insurance, but also thinking about so many other things as you're just entering adulthood in general?
Yeah, so I come from humble beginnings, so I was used to navigating being dropped by the insurance company or then changing my medication without telling me. So I'd kind of been used to that before I became like an official adult. Sorry, I'm 27 and I still don't feel like I'm an actual adult. Yeah, so anyway, when I was about the time I was 20, so I'd been diagnosed with the rheumatoid arthritis when I was 24, and that's kind of where I started to learn the more adult, I guess, approach to healthcare, particularly with my rheumatologist. So in particular, like that first appointment was the first chronic health appointment I went to by myself, because I obviously started diabetes with my parents. So this was kind of the first time that, like, this is like my, I guess, like my baby that I don't want, but it's like my, like, okay, I'm doing this myself. And so in that appointment, it was kind of a real wake-up call as to how the healthcare system that we live in now, you have to like basically cross like certain milestones in order to then move on to something else that would be more beneficial. So like for that first appointment, every joint in my body hurt. And I was in school at the time. I was in a program that was for people who wanted to be doctors like me, who had had like adverse experiences that may have impacted how much volunteer hours they could get, or the, even having energy to do things like that. So it was a really great program at the University of Arizona called the Pathways Program. So that was during COVID, and so I couldn't even go on Zoom because I was in so much pain. And I go to this doctor's appointment, and I'm like, just give me whatever I can take that's going to stop this, because I feel like it's causing permanent damage. It just felt that way. It was so bad. And we had a conversation about how I'm of reproductive age, and that the only medications that actually work are going to affect, like, they're teratogenic and can cause deformities. And I'm like, well, that's not on my plate right now, and I would like to consider it. He refused to give me that medication. And so now I'm on a medication that people take for COVID that I don't feel like does anything, and I had to be on it for a couple years to then get approved to then move on to a biologic. And then even that doesn't necessarily do, and I'm sure maybe you use a biologic for UC, even that, at one point, like tomorrow, it could not work. And then I have to start all over again. And then it's up to the insurance to determine whether or not I actually did enough work to then prove that this didn't work. And so I think, like, I guess that's a conversation for later, but just for people in policy, that's like a huge disconnect unless you know somebody or you have a chronic disease yourself that requires a biologic, for example, just because those are a lot more common now, is the work that goes into actually getting that medication is years. And then tomorrow it could be over and I have to go and start a new one and then get denied and then have to reapply. And so I think as an adult, that was really hard, and then my parents couldn't do anything to help me because that was with my personal insurance that I got through the state of Arizona. So, yeah.
Yeah, no, and I think what your story reminds me of, and so many folks that we work with, is that sometimes it's the systems that make the transition so much more difficult than the actual condition or the actual time period. So when we think about transitions and transfer of care, I think it's really crucial to promote self-advocacy, self-management, all of these skills, but also recognize that we have to be changing and looking at these systems, because it's unfair for us to be, on the phone with insurance companies for 12 hours, and it's just not practical, for anyone, let alone young adults. So Mani, I'm going to turn it over to you, going back a few years. So turning 18 is when you become a legal adult and can often mean a move away from family, which can be difficult to transition for obvious reasons. But what is your experience in taking charge of your care after turning 18?
Yeah, so I turned 18 last September, and it was just a complete flip. I think the most that I knew was, at 26, you get taken off of your parents' insurance. However, what I didn't know is that even though my dad, it's coming out of his pockets, and he's so happy about that, he called me one day, and he was like, okay, we need to switch one of your medications. However, the insurance needs your approval for it. And so, he was delighted to hear that I'm paying for my daughter's insurance, but she has to give me the check of approval. And that was about a 4 or 5 hour long ordeal back and forth with insurance. It was simply me calling them and be like, yep, my dad can, access my medical records. And then in terms of, I think my biggest issue has actually been at the pharmaceutical level. I turned 18, my birthday's a little bit later than most of my peers, and my mom stopped getting the reminder emails, text calls from CVS about, hey, Mania's prescription is ready to be refilled. So there was, this 1 week cram of oh my gosh, where are my medications? I'm running out of them. And so called CVS, got put to voicemail, and then it was, again, a whole ordeal. And they're actually like, oh, well, because you're 18 now, your mom cannot access your medical records. She cannot access any of your medications. You're going to have to approve that through the app. So downloaded the app because we love technology, did the whole process of it, and that was definitely super frustrating because it was almost every single time my prescription was getting renewed, I'd have to call them again and go through the entire process. And then I think another aspect for me, so when you're diagnosed with epilepsy as a woman of childbearing age, so around 16, wasn't in my plans anytime soon, like Taylor said, you are put on folic acid as a precaution, something that's used in prenatal vitamins. All of a sudden, my insurance stopped covering that prenatal vitamin, so I had to make the switch from a simple gel that was about this big that I had to take every morning and change it to almost like a powder tablet. And that was, again, a whole ordeal. I don't know much about medicine. My dad, I'm grateful he is a physician, so he has a little bit more experience in that aspect. I didn't know what I was doing. I was like, folic acid, what even is that? I know it's in my pill box, but that's about it. So that was really, really hard. Again, I think the emphasis for me, I haven't turned 21 or 26 yet. I'm still kind of in that bridge of 18 to 21. I'm still seeing my pediatric neurologist. But my biggest thing has been communication. Communication is super, super important. I mean, even outside of the medical setting. Communicating either doctor to patient, doctor to family, doctor to caregivers, doctor to all of the above. I think that is super, super important moving forward, and I think that I've been very, very lucky with my experiences as a patient. It should be a right that every patient has an amazing experience with their care providers. However, right now in the day and age, it is a privilege, so I do take my experiences and recognize that as a privilege currently, and hopefully as we move forward, it turns into a right for patients.
Yeah, thank you so much for that. And I think someone had what you were alluding to, who's sort of coordinating all of this care and the connections between healthcare professionals, potentially parents, the patient. And there is a question, I think, about nurse transition coordinators, or someone had mentioned something like that. And that's a model that we've seen is incredible if hospital systems have the opportunity to support a nurse transitional coordinator to be that point person, because our patient and age demographic inherently does need more help in navigating these systems. So, so for Taylor, and I'm really wanting to try to get audience questions too, so please hold those, and I think in a few minutes we'll transition to that as well. But for Taylor, see that you have collaborated with many researchers, lawmakers, and you yourself are a medical student. How have these roles changed your view of the healthcare ecosystem, and what do you think should shift?
I think, so some of this I picked up, like listening to a lot of you speak earlier, was how the medical school process doesn't acknowledge certain whether that's conversations or approaches that you have to take to patient care. And I feel like it's some gift, I guess, that again, just from bad situations, you pick it up. And I feel like it's, whether you believe in like faith or anything like that, I do feel like it's some sort of little mystery gift that I've been given to be able to then advocate for people who aren't, I think some of it's education. So a lot of patients aren't equipped to understand how the game that I know, I think it was Colonel Coffey talked about, like that this is a game that you have to learn how to play. And a lot of med students don't know that. And then a lot of policymakers don't know that, again, unless you have a child with it or a partner, husband, wife, whatever, where you're like, I have to deal with this every single month. And then having to basically prove that I'm sick every single time I need a medication, or you're meeting a new doctor or something like that. And so I think that it has been, I've taken it on as like a responsibility for when I'm in the clinic or when I'm talking. We have, these case-based instructions, and they give you this perfect vignette of like you read this and you know that that's UC or something. And it's like, yeah, but when you're actually out there in the clinic, if you start treating people that way, it's like you have to hit these check marks, and then that makes you this patient with this condition. You then miss things, and then you miss like treatments, and if you had this treatment, for example, I know there's like a hemophilia drug that's like $3.5 million, and it's like, you could tell a patient, I have a medication for your condition, but your parents are going to go bankrupt, and having to fight with your insurance company, and are they going to cover that? And so I think as a student, and then as someone who's been through it, you just have to keep educating people no matter how exhausting it gets. And some days you're going to be angry. And you're like, I don't want to talk about this anymore. But it just comes, I guess, with the territory. And I think even like for young patients and adolescents, like that's something that my mom really instilled in me, because she was like she's like my bulldog. So sometimes I have her fake call the insurance as me, because I'm like, I'm in class, I can't do it, and I need my CGM. And so like there are things that you can do, but it's like, is this legal? No, but it's a game that you created. So it's just, yeah. I think that there are ways around it, and I think if you can kind of just be like, I'm coming up to bat, and you better be ready. Like, I don't know. It's like, I've played your game, and it doesn't work, so now we're going to play it however I can get what I need. And so I think that that's something even for young patients to kind of, no one's going to do it but you, and that's really important, even like when we're talking about like going into the doctor for the first time, that it all, at some point, it's just going to happen one day, and you're like, I'm an adult and I can do this. And then leading up to it, it's like, I'm never going to be able to tell someone like, oh, I need my insulin, and this is who you call, and all that stuff. But I think that just ends up coming with the territory and giving your kid that opportunity to have like more adult responsibilities, that I think is really important when it comes to transitioning, and trusting them that you taught them what they need to do. So, yeah.
Yeah, that's a really important point, and I think what you're saying about like making it sort of a process is so critical too, because I think like we've heard from a lot of people that it starts out with teaching someone like, what medication are you taking? Do you know what your medication is for? So it's not just like an overnight thing. It takes years and years, and I think there's a lot of schools of thought that have alluded to like it should start at age 12 or 13 with asking these individual questions to try to get us prepared for that eventual takeover. And I think to your point about your mom calling, my mom just did that last week too. And
Exactly.
and I am also supposed to be like very high health literacy here, but it's hard. I mean, it's, so I'll be honest. No, but I think, it's the case for most of us who have care partners that are, still very much part of our lives too. So I think we'll do one more question for Manya, because I really do want to get to this. So you've done quite a bit of volunteering and work with the Epilepsy Foundation of Michigan to conduct an epilepsy needs-based assessment. Can you elaborate more on that work and share any learnings from that?
Yeah, absolutely. So I worked on this project from May of last year up until the January of this year. Like Sneha had mentioned in the introduction, this assessment was conducted to assess the medical needs as well as the quality of life across people with epilepsy, friends and family of people with epilepsy, as well as friends. I think it's really, really important to incorporate all of those different lifestyles, because I think we get so caught up in the patient's interaction, which is the most important interaction, how they're feeling and how their experiences are. But it's also good to look at their support systems and be like, how are these people affected? So we asked them about quality of life. The most important section that I really, really advocated for was the SUDEP section at the end of the survey. For those who do not know what SUDEP is, it is the sudden death of a person with epilepsy. The statistic is about 1 in 1,000, so a very small statistic. However, to me, it was that 1 in 1,000 is not a small statistic to the person that is that 1 in 1,000, and that is super, super important to recognize. So kind of looking at the data, I did the first set of data analysis, and we found that 53% of patients with epilepsy did not know about SUDEP up until this assessment, which did break my heart, because that was not the way that I wanted them to find out. It's a really, really tough conversation. However, it is a really important conversation to have. And then kind of tying back to what we're talking about at this conference today, people loved education and resources. They loved the websites, they loved webinars, conferences, newsletters. Those are really, really important and helpful to understand what's going on in their lives, but also connecting with people in the epilepsy community. For example, when I was first diagnosed, again, in the middle of COVID, it was really, really hard to talk to other people, because it is a really lonely experience, and I'm sure you guys know that as well as patients with chronic diseases. But the feedback that we got was education and communication are really, really important. So I think walking away from this today, it's just understanding how can we communicate with the greater communities, whether that's solely people with epilepsy, epilepsy communities, whoever's involved. How can we take that information, and I believe we talked about this in an early session, how can we take really, really complicated information and make it more readily available to the general population? I was very lucky with my neurology experience, but I know that having those words thrown at you, you're just kind of taking it all in at once. But kind of sectioning out that information and seeing how that can be beneficial but also educational is super important. But yeah, to tie it all back, that needs-based assessment told us a lot about the community. We also looked at demographic analysis. For those, from Michigan, you have the MIT, of course. The top part, Upper Peninsula, reported that they do not see their clinician at all. Transportation is a huge, huge issue, because we sit here and we kind of assume, you have transportation. I believe someone had mentioned clean drinking water. Flint, Michigan does not have great drinking water. Just kind of taking all of those factors into association and just remembering that these are real people with real feelings, lives, emotions, and just being gentle with that. And yeah.
Yeah, I love that so much. And I'm just celebrating this example because it's a real life example of patient-led research and patient-led advocacy, which I think is really important, and for those patient organizations in the room to be able to facilitate that is huge. So I'm really excited about that. Does anybody have any questions? If you want to make your way over to the mic, we can try to maybe take 1 or 2 questions.
Hi, guys. This has been really wonderful. Thank you for sharing your stories with us so openly. I do a lot of work with parents around transitioning, which is fun and interesting, and I use a lot of my own failures, I would say, as a parent of a daughter with hydrocephalus and epilepsy to teach other people not to do some of those things. But I'm actually curious, how was the transition process for your parents and for you guys as a family unit? And was there a time where did you feel like there was a gradual shift, or was it an all of a sudden? Because, you know, you're right, you guys both said it, a lot of people don't know, all of a sudden at 18, you can't access medical records, you can't access college grades, you know, academic records, and a lot of people don't know that. They're left unawares and they hit this block, like, oh my God, what is going on? Why can't I do these things? And sometimes we're talking about making life or death decisions in a hospital. And you need to have all of those documents in place. So I'm just curious, how did your parents transition, and how did you and your parents transition together?
Yeah, so that's a really great question. I'm glad you asked that. It was, again, 16 to 18. I had about 2 years to kind of come to terms with what was going on. The biggest obstacle to tackle was actually medication management. My neurologist was very keen on just, you need to be as independent as possible from an early age. Again, not to be like, okay, you have to kind of figure this out on your own, but like, Manya, when you can start driving again, why don't you drive to CVS, get your prescription yourself, of course, take your parents' credit card, don't put it on yours, pick up that medication yourself. Get the medication box, fill it by yourself. And of course, my mom, I love her to death, very helicopter when I first got diagnosed, would count all of the pills and make sure everything was fine. That was okay with me. But I think for me, my biggest thing was just understanding where they're coming from as well, which is super hard. My parents are both immigrants, so there was that disconnect there of like Western culture, but also understand that, yes, this is my experience, but they're going through it as well. So just kind of taking into account what I'm feeling, but also what they're feeling. It was definitely a rough transition. My mom was like, when I started college, she was like, I'm gonna drop your pill box off every week, like, I'll deal with it. I was like, oh gosh, yes, I live 10 minutes away from home, but comes with its pros and cons. It's just, you know, as a parent, letting your kid figure it out, which is really, really hard, I know, because you want your baby to always be your baby. But also as a patient and a child myself, just being like, your parents love and care about you so much. It's just finding that middle ground to where both parties feel happy, safe, and confident in the journey that everyone's kind of going through. So.
Do they still go into your medical appointments with you?
They do to my neurology ones. Again, I kind of have some other health issues going on, but they'll come to my neurology, which is about an annual one. But that is also just, I like having them there just so they're kind of informed. And then again, my neurologist's body language is great, addressing me directly as a patient, but also if they have questions and concerns, those are addressed as well. So,
Yeah, from my experience, I think just because, like, it's just a little different because I have had it for so long. So, I mean, we were going, 17 years if I always had a parent with me at a doctor's appointment. And I think one of the shifts that still to this day, like we talk about, can be hard, is that for type 1 diabetes in particular, and I think it was Miss Cole has a daughter type 1, but there sometimes is like a guilt factor that comes with like your glucose control. Or if you're going through something, or you're going through puberty was like insane. And you come to these doctor's appointments, and then it's a group effort. Like, why is your kid's A1C 8.2? Last time it was 7.9. And you're like, we're moving, or parents are getting divorced, or like life is still happening while you have these conditions. And so, like, my parents were always with me through that. But then, once I had to move out of my pediatrician's office, and I was with a new doctor, they treated me like an adult. Whereas with a pediatrician, there's like more tender loving, like, we're gonna take care of you, and like, you've been with us for so many years. And then you're put with somebody who doesn't know you, and then quite frankly may not actually care too much because they don't know you, that they haven't been with you for 10 years or whatever. So at some point when you ask, like, was it just one day where it stopped? There was a time where I think I was probably around like 21. She would still come with me because I had to, every time, like you were saying, I had to write her name down at every single appointment, even though you could see it in the chart. But there was a day where I was like, I think I'm gonna try it out on my own. And she trusted me enough, like having gone through all those appointments, and you know your kid, and I think most kids want to do their best when it comes to their health, and they're not doing anything because they're vindictive or like, I'm not taking my insulin because I want to make mom mad or something. I think that it's just trusting your kid and also letting them know, like, if it goes south, you have a support team. We love you, we're gonna take care of you, and it's gonna be okay. And I think that that's the best you can do in that transition period until they're like, I'm an adult and I can take care of it no matter, like, by myself. So yeah, I don't know how that is with UC. But.
Yeah, no, I would just echo a lot of the similarities there as someone who can't remember life's without ulcerative colitis. But I also think it's interesting because when you think about young adulthood, we think about oftentimes independence as this endpoint for success. And I think we probably don't want to move that way all the time because there's a lot of young adults who are unable to reach that by themselves fully, whether that's because they're too sick, there's just too many other factors in their life. And so I think it's really important when we're thinking about young adults and young adult patients in particular that independence is not the only sort of endpoint that we look at because it very much looks different for different situations. Do we have time for one more question, or no, you can be honest with me? No? Okay. Well, I'm kind of sad, but I shouldn't have asked. No. But I'm super excited. Thank you both so much for an incredibly impactful panel. I know I learned so much, and I saw a lot of my experiences in what you shared, and really hope that we can bring more young folks to platforms like these in the future too. So I'm now going to pass it to Leah Howard, President and CEO of the National Psoriasis Foundation, for some closing remarks.
Thank you, Sanea, Taylor, and Manya. I just want to say I think you've got a number of folks in this room that have been doing patient advocacy work for decades. And I think all of us just learned something from each of you. So thank you for sharing your journeys here with us today. I think that really extends to all of the speakers that we've heard today. I think each of the speakers in each of the sessions have just been tremendous. And we've learned everything from how best to interact with patients and victims who have experienced sex trafficking and gender-based violence, to best practices for caregivers, families, and pediatric populations who may be struggling with a new diagnosis for their children. We also heard the special considerations when engaging with adolescents and caregivers. And finally, with our excellent young adults panel, who gave us a lot of insight and wisdom into how crucial the care transition period is. If you're like me, Randy and Omar know that I love to sit in these sessions and try to think about ways that the National Health Council can solve the challenges that we've heard here today. But I think each of our speakers and each of the panels really gave us a number of questions that we as a patient community need to be thinking about. And so I know I'm gonna go home tonight and reflect on some of the work that maybe we could do collectively together to tackle some of these issues, and would encourage you as you're thinking about the sessions and the speakers you heard today to do the same and to bring your ideas back to the National Health Council. I also want to second the comments Katie made at the start of the day that if you're not a member of the NHC and you're thinking about joining, please do talk to Randy and the team. It's an excellent organization, and we'd love to have you be a part of it. So now I would like to invite those with red dots on their badges to a special reception next door, where NHC members will present posters of their patient engagement work. You can network with your fellow researchers, executive leaders, and patients advocates. I hope everyone also joins us tomorrow for day 2 of the symposium. Our opening keynote will be Dr. Kapil Parakh, the senior medical lead at Google, and our closing keynote will be Dr. Namanje Bumpus, Chief Scientist and Principal Deputy Commissioner at the FDA. There will also be panels on women's health and ageism, as well as an important presentation from PCORI. So with that, day one of the Science of Patient Engagement Symposium is concluded, and we look forward to seeing you tomorrow at 8 a.m. Thank you so much.